Hello, my name is Jason Wilmoth. I'm an interventionalist in Portland, Oregon, and I was asked to talk today about embolization of thrombus, air, and other debris. Here are my disclosures. Intracoronary thrombus can be broken down into a non-iatrogenic and iatrogenic thrombus. Non-iatrogenic thrombus can come from coronary thromboembolism from atrial fibrillation, LV thrombus, or intracardiac shunt, or in situ thrombus from patients with aneurysms or thrombotic disorders. Finally, obviously, we see this very commonly in acute MI, and this can either be at the lesion or with distal embolization. Iatrogenic causes include device-related thrombus, injection of thrombus from a guide, distal embolization leading to slow or no reflow, or embolization during other cardiac procedures. Treatment of intracoronary thrombus falls into generally two categories. One is to remove the clot, either with mechanical or manual thrombectomy devices. This is what's most commonly used. Other potential options including embolic protection devices to either prevent distal embolization of the thrombus or to actually pull the thrombus back into the guide. Finally, a neurologic device, the solitaire device, is a stent-like apparatus that can be expanded to help entrain the thrombus and help remove it. Treating the clot obviously requires adequate anticoagulation. 2B3 inhibitors and P2Y12 inhibitors are also a mainstay if there's a significant amount of thrombus. Intracoronary thrombolytics have also been used at a dose of approximately 5 to 10 milligrams of intracoronary TPA or alteplase. Stent exclusion can be used for a stubborn thrombus that is not able to be removed, and laser atherectomy can also be helpful in ablating thrombus, particularly in vein grafts or in ectatic coronary arteries. Next, we're going to show a few cases of intracoronary thrombus and management of them. This is a patient with an inferior STEMI with an occluded right coronary artery. Most physicians are familiar with a variety of different mechanical or aspiration thrombectomy devices, and this was initially treated with a CAT-RX thrombectomy system. Use of the thrombectomy device was able to restore flow into the vessel, but you can see that there was a marked amount of thrombus still remaining. Further attempts with passing the device were not able to retrieve the significant amount of thrombus. At this point, the 6 French guide catheter was passed down the right coronary artery, and the back end of the guide was hooked up to the suction device, and the guide itself was used to remove the thrombus. After this was performed, there was a significant improvement in flow with removal of all the thrombus. You can see in the catch basket there was a marked amount of thrombus seen. Follow-up angiography showed a large aneurysm in the mid-right coronary artery. There was no significant underlying atherosclerotic disease requiring any further treatment other than long-term oral anticoagulation. Next is a patient who presented with unstable angina, was found to have a high-grade LAD and diagonal branch bifurcation stenosis. This underwent DK crush bifurcation stenting that was complicated by difficulty wiring and then rewiring back through the crush stent into the diagonal branch to perform both kissing balloon inflations. During the procedure, the patient did develop some chest pain and EKG changes. Ultrasound was performed after we were able to get back through the stent struts, which showed some thrombus at the bifurcation, though the stents themselves appeared to be relatively well expanded. Thrombectomy and further ballooning were performed at the bifurcation, and follow-up angiography showed restoration of flow. Device-related thrombus can be difficult to manage. Obviously, adequate anticoagulation is needed, so checking an ACT is important. Consider adding a 2B3A inhibitor or cangrelor if needed. Thrombectomy at the lesion site or additional ballooning and stent optimization can also be performed to help restore flow. Finally, it's important to consider intracoronary imaging to identify any potential mechanical issue. Next is a patient who underwent transcatheter aortic valve replacement. After the procedure in the holding area, the patient was noted to be hypotensive and had EKG changes, and an echocardiogram showed some anterior wall hypokinesis. Angiography Multiple attempts to remove the thrombus utilizing thrombectomy devices was not successful, and given the location and the patient's hemodynamic instability, it was elected to simply stent the lesion to exclude the thrombus from the vessel, and the patient subsequently did well. No discussion of thrombus in coronary arteries is complete without talking about slow and no reflow. This occurs in 1 to 3% of all PCIs and has been defined as either being structural from prolonged ischemia leading to endothelial swelling and microvascular obstruction, or functional secondary to distal embolization of microthrombus or micromaterial from a ruptured plaque leading to microvascular obstruction. When you encounter slow or no reflow down a coronary artery, it's important to rule out other causes such as dissection, spasm, or thrombus. The mainstay of treatment is intracoronary vasodilators with adenosine, calcium channel blockers, and nitroprusside. Occasionally, intracoronary epinephrine is needed. Direct delivery to the distal vascular bed via a microcatheter, manual thrombectomy device, or a dual lumen catheter can be useful. Finally, intra-aortic balloon pump can be helpful in increasing coronary perfusion pressure. During this case, we had difficulty restoring flow down the vessel despite copious doses of intracoronary vasodilators, IC epinephrine, as well as an intra-aortic balloon pump, but by the end of the procedure, we had restored flow to the distal vessel, though still somewhat slow. Next, we're going to talk about air embolisms. This is a patient who underwent successful RCA CTO PCI because of recurrent graft failures. We got an excellent angiographic result, but still had significant flow in the graft, and because of this, we passed a guide catheter into the ascending aorta with plans of coiling the graft. The patient then developed chest pain and had EKG changes. Angiography of the native right coronary artery showed no change in the anatomy, with still good flow up the graft, but we could see that there was staining in the vein graft going to the circumflex system, and angiography of this confirmed an air embolism in this graft. Air embolization is a rare complication of coronary intervention, occurring in 0.1 to 0.3% of all angioplasties, the vast majority of which are iatrogenic. These commonly can come from inadequate guide catheter aspiration or flushing, introduction or withdrawal of balloons, microcatheters, or guide wires, balloon rupture, though this generally leads to a very small amount of air, broken or disrupted manifold. The other thing that can be common in the CTO world is entrained air from trapping balloons, and rarely you can see a paradoxical air embolism via an intracardiac shunt. Treatment of air embolism starts with making sure that any residual air in the system is removed. The patient should be given 100% oxygen, which promotes nitrogen diffusion from the bubble to decrease its size. You should support hemodynamics with inotropes or intra-aortic balloon pump, which can increase blood pressure to promote air passage. Forceful injection of blood saline in contrast can be used to dissipate the air. Vasodilators can be given if there is slow reflow. Stirring of the bubble to break it up into smaller bubbles can be done, which leads to faster resorption. And finally, aspirating the air with a thrombectomy catheter, guide extender can be done. In this case, we were able to pass a thrombectomy catheter down the vein graft, and after multiple passes, removed a significant portion of the air, which restored brisk flow down the graft and resolved the patient's chest pain and EKG changes. So in conclusion, coronary embolisms are rare but potentially lethal, and there are a variety of causes and treatments. Minimizing iatrogenic causes by adequate anticoagulation with frequent monitoring and meticulous management of the guide and manifold. There is no one-size-fits-all treatment, and you should be familiar with a variety of options for removing embolisms and treating subsequent sequelae. Thank you very much for your time. Showed evidence of thrombus in the left main. Review of the TAVR deployment showed evidence of potential thrombus hanging off of the leaflet of the valve, and it was felt that this was the origin.